Good morning, students. Today, whatever is left over from renal that day which we started, I will complete that very quickly and then we'll proceed to the WBC disorders. So, renal stones, the types of renal stones and the pathogenesis may be a question in your paper. So, but of these, the most commonly asked is the renal cell carcinoma. And the classification of renal cell carcinoma in practical viva is extremely important. You have to know what are the types of RCC based on histology. And that is basically the thing about RCC. This is a question which I think you have gone through. And the diagnosis here is obviously renal cell carcinoma. Okay, so what you have to see, what are the clues in this history is that it's an older gentleman and he's got fever and he's got 4+ blood in the urine, but there is no protein, no glucose, no ketones. And another thing is the main complaint here in this is that he's got hematuria. So an older gentleman with hematuria, you definitely should think of a renal cell carcinoma. So your next step would be a CT scan to look for a renal mass. Okay, so that is the answer, abdominal CT scan for a renal mass. That will be your answer. Wilms tumor can come as a short notes, and sometimes these are questions which are asked in objective questions, like for NEET and all, they like asking these type of questions. Associated increased risk in developing Wilms tumor, WAGR syndromes, Danish-Drash syndrome, Beck-Wiedemann syndrome. At least if you know this slide, it's more than enough. Now, these are the things which we keep in your practical exams, the renal charts. So in your practical exams, we give very simple history. 4-year-old boy, generalized swelling, that means he's got anasarca, 5 days, puffy eyelids, BP is within normal. So in the practicals, we will keep a urine examination, which is already done. Okay, so in this case, urine examination appearance is turbid. The urine protein is 3.8 for 24 hours. That means there is massive proteinuria, and cholesterol is on the higher side. So looking at this history, obviously your diagnosis will be it's a nephrotic syndrome. Okay, and narrate 4 points in support of your diagnosis. From this history only, you can narrate 4 points. He's got anasarca. His BP is normal, the urine appearance is turbid, he's got massive proteinuria, he's got hypercholesterolemia. So these are the 4 points in support of the diagnosis. What further investigation is required? Apart from the urine examination, your urea, creatinine will be required, and of course a biopsy. And what finding will confirm the diagnosis? This one is a 4-year-old child. So you expect the cause for nephrotic syndrome to be minimal change. And like I said, minimal change disease will be normal on light microscopy, and there will be no immune deposits on immunofluorescence. However, the diagnosis is based on the finding of loss of food processes on electron microscopy. And that is the finding which will confirm the diagnosis, minimal change nephropathy causing nephrotic syndrome in a child. You will get normal light microscopy, normal immunofluorescence, but loss of food processes on electron microscopy. That is the main thing. Okay. This is another similar question. 6-year-old boy, again anasarca, puffy eyelids, BP is again within normal. The urine sample is provided. So we provide a urine sample here, and we can, like these are the questions which we ask, interpret the urine test provided. So we usually keep one protein sample which has been done. You have to see that it's 4+ urine, you have to interpret that. And we have, usually we keep glucose, sugar for protein, which will be negative in this case. So we'll give 2 tests, and then if we give only the protein or we give along with sugar, we name the test tubes 1 and 2, and we ask you in the test tube 1, if it is protein, what other 2 substances can be used, 2 methods to measure the substance in test number 1. That is, in the protein test, is there any other way you can measure protein apart from doing a heat protein test? Okay, so you have to know the other methods of measuring protein in the urine. Clinical diagnosis, it's a nephrotic syndrome. This by now you know. So this again is a 42-year-old anasarca. She's got hypertension. The urine is provided as usual. We'll give a protein and a glucose. The urine microscopy is given here, 4 to 5 high power field. For a lady, this is quite okay, 1 to 2 RBCs, mild hematuria. Total protein is 3 grams, just borderline of massive proteinuria. So she has got hypertension and she has got lots of protein in the urine. So you should again think along lines of nephrotic, maybe mixed with a little bit of nephritic, but in this case, because the protein is 3 grams per deciliter and the other urine microscopy is not very significant, and the urine provided here will be giving you massive proteinuria, 4+. So we expect you to interpret the test. Your provisional diagnosis will still remain nephrotic syndrome. In adults, nephrotic syndrome may have hypertension, okay? And name 2 common causes for this disease. In an adult, you have to know what are the causes for nephrotic syndrome. So in this case, the most common cause in adults is FSGS followed by membranous. And if the patient had been a child, what would have been the most common etiology? It's minimal change. This is a classical picture of immunofluorescence. This is, the history is also very classical. There is anasarca, 33-year-old female. Malar rashes. If there's a female with malar rash, photosensitivity and swelling of the joints, it is usually SLE. Okay, so the diagnosis will be SLE. The test which we'll provide will have like in urine microscopy, they've already said RBCs is more than 50 per high power field, and there is red cell cast. So this means that there is hematuria and there is red cell cast, and there is a lot of leakage from the glomeruli, allowing red cell cast to come. Red cell cast means clumping of RBCs. So the diagnosis here is SLE. The urine test, we will provide a protein. In SLE, there is definitely proteinuria. So heat test will be given, 2 or 3 plus proteinuria will be provided, and you have to interpret that. Name the diagnostic test done on serum. This I think you know. We do anti-nuclear antibodies, and the diagnostic test is anti-double-stranded DNA. Okay, anti-nuclear antibody is a very sensitive test. It is usually positive in SLE, but it is not diagnostic. You remember that. So the question here is name the diagnostic test. The diagnostic test for SLE is anti-double-stranded DNA. Okay, anti-dsDNA. That is the answer here. What investigation? This is immunofluorescence. Then this is a history. 8-year-old boy, sore throat, fever, swelling of feet, facial puffiness, decreased urine output 3 days, and you have urine microscopy which shows hematuria. So this, with this picture of an enlarged glomeruli, very busy glomeruli, very hypercellular, lots of cells in the mesenterium and also blocking some of the capillaries. So you know that this is a proliferative glomerulonephritis with the history, and that too with history of sore throat and fever. You know that you're probably dealing with an acute post-streptococcal glomerulonephritis. So the diagnosis here is acute post-streptococcal glomerulonephritis, and usually for this, we in acute post-streptococcal glomerulonephritis, you usually get Coca-Cola urine. That means that the urine is just like the color of Coca-Cola because of the hematuria which is happening, which has been, the lysis has happened inside, so it's formed some kind of pigment, so it becomes brownish. So we usually give around 50 ml of a Coca-Cola colored fluid, okay? And you're supposed to write the physical characteristics, meaning from the appearance that it's Coca-Cola, what is the volume, 50 ml we'll give you in a measuring beaker. And then you'll have to mention what are the other physical characteristics, like any smell, what is the color, what is the odor, okay? And the specific gravity has to be mentioned, even though we don't provide you with a specific gravity to do, but you have to write that you're going to do the specific gravity of the urine also. So that will be the physical characteristics, and you can interpret the test, which we will provide. We will provide a protein and glucose, and glucose is usually negative. Protein will be a little bit positive, but not very high grade, okay? Then we have here 65-year-old peripheral neuropathy, swelling of feet, puffy eyes, BP is high, hemoglobin is 9.4, Random blood sugar is 280, so it's raised. Urea is raised. Creatinine is also raised. So looking at this and looking at this picture shows you this typical lesions which are nodular glomerular sclerosis. I remember telling you to read up on diabetic nephropathy. You have to read up all the findings which are seen on renal biopsy, and one of the classical findings which can come as objective question is also nodular glomerular sclerosis or KW lesions. Okay, so this picture is given. You can, from the history with the blood sugar and the thing, you know that it's a diabetic presenting with renal failure. Okay, so that will be your diagnosis here. Characteristic lesion is KW lesions, and we will provide you urine. One will be sugar in the urine, which you have to interpret the color change, and you have to grade the amount of sugar in the urine. And another is ketone body. We might give you a positive ketone body reaction for you to interpret, and in that case the diagnosis would be diabetic ketoacidosis with renal failure. Okay, so that is diabetic nephropathy. So that is the end of renal. I will now go ahead and start with the WBC disorders. So coming to WBC disorders, I have made a whole lot of slides for you, 67 slides, but I'm going to go through probably 1-2 seconds per slide just to show you what is important for your exams. So before we go into that, I would like to provide some concept on this slide. Okay, so this is how the blood cells mature in the bone marrow. So we have a hematopoietic stem cell, and depending on what are the growth factors. Okay, so like I said, WBC disorders, I have some 67 slides, but I'm not going to really teach you. I'll just tell you what are the important things. But I feel this slide is extremely important. If you get the concept here, you will be able to follow me even if I go very fast. So this is what happens within the bone marrow. These are the cells which are formed within the bone marrow. So we have a hematopoietic stem cell here, okay? And this hematopoietic stem cell, depending on the factors which act on it, will form a common myeloid progenitor, which is a stem cell, and a common lymphoid, which is a stem cell. But at this level, they are committed. That means this stem cell will give only myeloid cells, and this stem cell will give only lymphoid cells. So they are committed stem cells at this point. This is the stem cell which is not committed yet. So depending on the factors which act on it, you may change this cell into anything. Okay. Now, when you look at the common lymphoid progenitor, see in this case, cells are very few. The common lymphoid progenitor, lymphoblast, is the cell which is the most immature cells in the lymphoid series. And this lymphoblast, again, depending on factors acting on it, will produce B lymphocytes and T lymphocytes. And T lymphocytes usually come from the thymus. Okay, so these lymphoblasts go from the thymus. Thymus produce the T lymphocytes and come back to the bone marrow. And this is the B lymphocytes. And B lymphocytes, when they mature further, they mature into plasma cells. So that is the lymphoid component. Okay, so B lymphocytes, T lymphocytes, and plasma cells from the maturity of the B lymphocytes. So this is important because when we deal with cases in which there are so many cases in which lymphoid cells can proliferate, okay, especially in viral disorders. If we have a viral disease, it is the lymphocytes which are the ones which are increased in our blood, okay. So especially in children, 1-year-old children, they get a lot of lymphocytes in the blood, and the danger is that they may be misdiagnosed as leukemia because the number of cells will increase, and they already in their normal counts, lymphocytes are more in children, but in reactive viral conditions, the lymphocytes will be even more, and they look a little bit transformed. So it may be misdiagnosed as leukemia. So it is, for pathologists at least, it is very, very important for us to know about the clinical history, because if a child comes with only fever and we see increased counts and we see reactive lymphoid cells, we should think of a viral fever. But of course, if the child also has hepatosplenomegaly and has lymphadenopathy, then it is dangerous. Then in that case, we have to consider leukemia. Okay. Then the next is the common myeloid progenitor. This is very important because if we say myeloid, we think only of neutrophils. Okay. But the fact remains is from this common myeloid progenitor, if you observe this picture, there is a myeloblast, and the myeloblast is the most premature cell of the myeloid series, and they will give all the WBCs, that is the basophils, the neutrophils, eosinophils, monocytes, and lymphoid cells come from the lymphoblast, but the myeloblasts give these in the peripheral blood. Okay, but if you notice, the common myeloid cells also is the parent of the thrombocytes or the platelets, and also of the erythrocytes or the RBCs. Okay, so this is very, very important for you to understand, because when cells of the myeloid series proliferate, it may be a reactive condition. Like in infections, you get a lot of neutrophils, which is neutrophilia. In parasitic infections, you get a lot of eosinophils. In usually neoplastic conditions like chronic myeloid leukemia, the basophils will proliferate. In chronic infections like tuberculosis, the monocytes will proliferate. So those are at least these are reactive conditions, and basophilia usually occurs in neoplastic CML conditions. Okay, so the myeloblast is the parent of all these WBCs. However, erythrocytes and platelets also come from the myeloid progenitor. That's why if you have read acute myeloid leukemia and acute lymphoid leukemia, you will find that acute myeloid leukemia, at least the French, American, British classification, there are so many M0s up till M7, right? 8 types. Because from the M0, that means these cells are the ones which proliferate. Okay, they are the most immature cells. Then the M1 means that the myeloblasts are the ones proliferating. And the M2 is something between this and this. That means this will proliferate. And also the mature cells will proliferate alongside it. And but if the myeloblasts are more than 20%, then you call it acute leukemia. Okay. And M3 means that after myeloblasts, there are certain cells like promyelocytes, myelocytes, metamyelocytes, band cells, then only these mature cells come. Okay. So the promyelocytes, if they proliferate, that will be AML M3. And M4 is when the pro-monocytes proliferate along with the monocytes. M5 is when the monoblasts proliferate. M6 is when the erythroblasts proliferate. And M7 is when the megakaryocytes, which are the precursors of platelets, proliferate. So you know that acute myeloid leukemia does not mean only myeloid, does not mean only WBC. It also includes the erythroid and the thrombocytes. Okay, so that is very, very important basic knowledge you have to know. Because in medicine, they will ask you this, why acute myeloid leukemia is so vast, okay? Because the common myeloid progenitor also gives rise to erythrocytes and thrombocytes and the myeloid cells, okay? Whereas a common lymphoid gives rise only to the T, B lymphocyte, and the B lymphocyte matures into a plasma cell. So I hope you're clear about this, okay? So when you deal with WBCs, if there is low counts, that is known as leukopenias. If there are high counts, they are known as leukocytosis. And leukocytosis may be reactive, may be neoplastic, and it may be any of these. If it's lymphoid, myeloid, or if it is plasma cell proliferation, those are known as myelomas. So this is a condition in which the neutrophils are very, very low. Neutropenia. And we call this condition as agranulocytosis. You know that WBCs are the ones which fight infection. In this case, there is a specific deficiency of the neutrophils, and so there is no ability to fight infection. And patients present with multiple ulcers in the gums, in the lips, in the mucosa, oral mucosa. And this is oral thrush, that is candidal or fungal infection of the oral cavity. So this is a peripheral smear showing you how normal peripheral smear will look like when the counts are normal. Okay, so you can see the space between each WBC is quite wide, but here you can see that there is a proliferation of the WBCs, and most of the WBCs here are neutrophils. So when you get the total count increased and the differential count of the neutrophils beyond 80-85%, then you call it a neutrophilic leukocytosis. But if the total count is normal, but your differential count is in neutrophils is above 80-85, you call it neutrophilia. Okay, so this is neutrophilic leukocytosis. So this we will not ask you in pathology, but it is important for you to know as a clinician. And of course, neoplastic proliferation, you can see the difference. These are immature cells, they are not lymphocytes. Lymphocytes are basically around the same size as RBCs. Okay, Small lymphocytes are around 7 microns, RBCs are around 7 microns. And here you can make out that these cells are at least 4 to 5 times the size of RBCs. So these are definitely blastic cells. Okay, so this is a neoplastic proliferation, and these blastic cells have come into the peripheral blood. So this is definitely leukemia because more than 20% of the cells are blastic. And this is when I was telling you that especially in children and also in adults who have infectious mononucleosis, we may have a reactive population of lymphoid cells. We call them atypical lymphocytes because they are just like those blastic cells. They are 4 to 5 times larger, but the amount of cytoplasm is a lot. And when you see these, can you see this RBC, and the cytoplasm is not pushing the RBC but actually allowing it to accommodate? Okay, so this is known as skirting of the cytoplasm, which is a characteristic feature of lymphocytes which are reactive due to some viral condition. Okay. So all these look like blastic cells, but they are actually reactive lymphoid proliferation. And they are very difficult sometimes to differentiate for a pathologist. This, I'm sure you know, these are the eosinophils. They have these coarse orange granules in the cytoplasm. So this is a case of eosinophilia. You have to know all the causes for neutrophilia, eosinophilia, basophilia, monocytosis, lymphocytosis. You have to know the causes. Okay. Then this is when there is proliferation of blasts, which are myeloblasts, and you are seeing this R rod here. These R rods are basically lysosomal aggregates, and these are characteristically seen only in acute myeloblastic leukemias. Sometimes in peripheral blood we might get many blasts, but if we do not find an R rod, we cannot call it AML. We have to say acute leukemia if it is more than 20% blast, but we cannot differentiate on peripheral blood smear whether it's a myeloid or a lymphoid. And we have to do further investigations to reach to that conclusion because the treatment and the prognosis is totally different. So this is what I was saying in AML, M5, these are all monoblasts. This is M6, that means these are erythroblasts, and this is M7, which are megakaryocytes. So all of them are acute myeloid leukemia, but they have a very different morphology because the cell of origin is different. These are from the erythroblasts, these are from megakaryocytes, and these are from the monoblasts. And I'm just putting these pictures because these are the questions which may come as objective type. When you have hypertrophy of the gingiva like this, you can see that the gingiva is totally hypertrophic. These cases usually happen in M4 or M5. M5 is mostly monoblastic, M4 is monoblast along with promonocytes and monocytes. Okay, so these cells are basically, when they proliferate, they infiltrate into the tissues. That's why you get a lot of gingival hypertrophy in AML, M4, M5. Okay, so this could be an objective question. And you may also get skin infiltration. This is known as leukemia cutis, which is more common in M5. Then myeloid neoplasms. These are myeloproliferative neoplasms or chronic myeloproliferative disease. Now the CMPD is now known as MPN. Okay, and these are the diseases within the MPN: chronic myeloid leukemia, polycythemia vera, primary myelofibrosis, essential thrombocythemia, and myelodysplastic syndrome. And the most important for you is chronic myeloid leukemia. You have to know everything about chronic myeloid leukemia. Even if you don't know much about the other 4, it's okay, but chronic myeloid leukemia is extremely important, and it can come as an analytical question. And you have to know about Philadelphia chromosome. I'm not going to tell you what it is. You should know by now. BCR-ABL. It may come as objective question. It may come as genetics of CML. You have to draw this, a Philadelphia chromosome or a BCR-ABL. Which chromosome into what chromosome, you have to know all that. Okay. And CML, the basic thing about CML is that there is a shift to left. Now, what do you mean by a shift to left? A shift to left means that usually in the peripheral blood, you get neutrophils, lymphocytes, eosinophils, monocytes. That is what you normally get in the peripheral blood. But in the peripheral blood of a CML patient, you get shift to left. And shift to left means that the myeloid series, which are the immature cells, they come into the bone marrow. And basophils also proliferate. So this is a picture of a basophil, and these are basophils here. Okay, so usually in peripheral blood, basophils are very, very less than 1%. But in CML, you get basophilia, and you get this shift to left, meaning that the myeloid cells which are immature come into the peripheral blood. So this is the bone marrow aspirate, which shows all types of myeloid cells which are increased in chronic myeloid leukemia. You have to know the phases of chronic myeloid leukemia, which is basically dependent on the number of blasts in the peripheral blood. Okay, so I will distribute these, I will send these slides to you if you wish, and you can go through it at your own pace. Then this is all CML, I think you can read up. And this is another point which I want to make a comment, is the leukemoid reaction versus leukemia. Okay, leukemoid reaction is something which is important for you, especially when you enter clinics. And in this case, in leukemoid reaction also, the total count can go very, very high, and you might suspect leukemia. Okay, so how do we differentiate between these two? So the differentiation starts from the clinical picture. Leukemoid reaction usually occurs in patients who have infection, and usually patients who are immunocompetent. Okay, if they are immunosuppressed and they have infection, the WBC count will usually not go high. But in immunocompetent patients who have severe infection, the WBC count can go very, very high. Okay, so the clinical picture is infection, leukemoid reaction. In leukemia, you usually get organomegaly or lymphadenopathy. The total count can go up to 1 lakh, but usually it's within 50,000 for a leukemoid reaction, and a leukemia, it can go even above 1 lakh. But this doesn't mean that a leukemia cannot happen with 10,000. It may still happen. Okay, the basis of diagnosing leukemia is based on the cytology of the cells, not only on the total count. That you will know as and when you go into the clinical side. But as of now, you remember that up to 1 lakh is leukemoid, and more than 1 lakh is definitely leukemia. Immature cells, the blast cells, this is absolutely important. This is in fact the most important. If you find myeloblasts or lymphoblasts more than 20%, it is definitely leukemia. Okay, toxic granules because of infection, this is usually seen. Here it's not seen. Anemia may be slight, here it is present, and progressive. Progressive is a very, very important word, because when a patient is admitted with you, you give the complete hemogram today. After 3-4 days, you again test the complete hemogram. If initially he came with 9 grams hemoglobin, and within a period of 5 days, his hemoglobin went down to 7, even though you have started him on hematinics or given a good diet, then but the hemoglobin is still falling, that is known as progressive anemia, and that is a very important sign that there could be something neoplastic going on. Nucleated RBCs it doesn't really matter if you don't know this. This is very important. Leukocyte alkaline phosphatase, in this case, it is normal or increased in leukemoid reaction, and it is decreased in leukemia. This is not in all leukemias, it's basically in chronic myeloid leukemia, because the difference for leukemoid reaction is with a neoplastic leukemia is the chronic myeloid leukemia, not the acute leukemia. Okay, so maybe here we should have labeled this as chronic myeloid leukemia. Okay, and this is a very, very important objective question also. The difference between leukemoid reaction and chronic myeloid leukemia is that LAP is normal or increased in leukemoid, and it's decreased in leukemia, in CML. Platelet can be normal or increased. Platelet doesn't really matter in CML because it's a myeloproliferative neoplasm. I told you myeloid means it can be platelet, can be erythroid, so the platelets may be proliferated. Unless in a blast crisis, the platelets may go down. That is a very important point you have to remember. In a blast crisis of CML, the platelets go down, because in a blast crisis, the blast cells may be more than 20%, and the picture can change into something like an acute leukemia, except that there is a history of CML and he's gone to blast crisis. That's the only difference. Bone marrow is usually hyperplastic, and the blast count is low in leukemoid reaction. Polycythemia vera, it's because the RBCs are crowded. Myelofibrosis is because of fibrosis of the bone marrow. And in myelofibrosis, because of the fibrosis of bone marrow, the RBCs have to squeeze in, and so they come out looking like this. they have a teardrop shape. Okay, so that is very important. It's a feature of myelofibrosis. Essential thrombocythemia is when the platelet count is very, very high, and you can see these are clumps of platelets in the peripheral blood, and in the bone marrow biopsy, we get clumps of megakaryocytes, which is absolutely abnormal finding. Okay, and this table, I think you go through it, this table. I have marked in red whatever is really important, how to differentiate between these 4 MPNs. Okay, so you can see the cells mainly proliferated. And one thing which is very important is the spleen. In myelofibrosis, there is always massive splenomegaly in myelofibrosis. In CML also there may be massive spleen. It is bigger than the other two. Okay, then lab score here I told you is decreased. Bone marrow fibrosis sets in very early in myelofibrosis, but it can go into, all of them can go into secondary myelofibrosis. This we are talking about primary myelofibrosis, when there is early fibrosis. All the other MPNs can go into myelofibrosis, that is known as secondary myelofibrosis. So it can go in the transformation phase, and all of them can transform into AML. And the most important here you can see is the genetic mutation. That's why we talk so much about BCR-ABL, because BCR-ABL is diagnostic of CML, whereas JAK2 mutation is there in all 3 of them, and it might be difficult to differentiate based only on genetics for these 3. But BCR-ABL is unique and specific for CML. MDS is when you have a lot of dyspoiesis. Dyspoiesis means when they look abnormal. See, if you look at this, it looks like an eosinophil, but if you look at the cytoplasm, there is no orange coarse granule. Okay, so this is basically a neutrophil which is hyposegmented and which is just attached to each other like with a nuclear bridge here. So this is a Pelger-Hue abnormality which is seen in MDS. This is erythroid cells. Again, you're seeing a nuclear bridging here. This is abnormal erythroid cells. These are megakaryocytes. Megakaryocytes are usually lobated, but here there is no lobation. It's just one single nucleus, so it's hypolobated megakaryocytes. Another feature is the erythroid cell. When you stain it with iron, you can see iron granules around the erythroblast nucleus. So these are known as ring sideroblasts. Okay, so these are features of MDS. Now, lymphoid neoplasms, you have to know this. This is from the WHO classification. And from this classification, if you go through, the most important which you have to know is the CLL, SLL, okay, which we do ask questions. The others, you'll have to know at least a little bit about it, not so much. Myeloma is very, very important. Burkitt's lymphoma can come as a short note. You have to know some IHC markers and all that. Okay. Then peripheral T-cell neoplasms, this Sézary syndrome, objective question can come. These we don't really ask you. So all those are marked, the important ones are marked in yellow. Hodgkin's lymphoma is extremely important. You have to know the classification thoroughly. And if we do ask short notes, we might ask on one of these. So in ALL, you have to know everything about ALL. It's extremely important to know everything about ALL. I'll send these slides to you, and you have to know what are the positive markers in ALL, and which is the B cell marker. It is CD19 and 20, and the T cell marker is CD3. Okay, so these, you have to know these kind of things because these may come as objective questions. And then the next question which may come is to differentiate lymphoblasts from myeloblasts. So in this case, based on morphology, lymphoblasts are usually smaller, myeloblasts are usually larger, and lymphoblasts have a high NC ratio, and the nucleoli is not really seen because the chromatin is very dense in a lymphoblast. But a myeloblast, the nucleoli are multiple. The chromatin is quite fine. I have not written down here, but the chromatin in myeloblasts are usually finer, so you can appreciate the nucleoli very easily. Okay, and these are the markers which can be used, and these are the markers which can be used for myeloblasts. These are the cytochemistry. We can give a question on what are the cytochemical stains which are useful in differentiating lymphoblasts from myeloblasts. So the most important thing is myeloblast is myeloperoxidase and Sudan black positive, and lymphoblasts are positive for periodic acid shift. These are the most important as far as cytochemical stain is concerned, and it may come as a question. Morphologically, R-rot is the only diagnostic feature for AML. If we find an R-rot on peripheral smear, we are confident to say it's acute myeloid leukemia. If we don't find an R-rot, we just say acute leukemia. We cannot go further than that. And we have to do bone marrow, we have to do flow cytometry to see what are the markers which are positive and whether it's a myeloid leukemia or a lymphoid leukemia. Like I said, because the treatment is totally different. So these are the lymphoblasts in ALL. The genetics of ALL is extremely important. You have to know about this because this can come as a question. And clinical features, analytical question always comes, so please read through the clinical features. Lab findings of ALL, I think if you go through this, you will understand what it is. And the good prognostic indicators are very, very important. The prognostic indicators in ALL, the good and the bad prognostic indicators are extremely important. You have to know this. And then B-cell neoplasm, CLL, SLL. This one also, the basic difference between CLL and SLL is that CLL is when the cells are seen in the peripheral blood, and SLL is when the cells are seen only in the lymph node. Okay, so basically small lymphocytic lymphoma is restricted to the lymph nodes, but when it spills over to the peripheral blood, then we call it chronic lymphocytic leukemia. Okay, so lymphomas, when they spill over to the peripheral blood, they become known as leukemias. Okay, so this CLL, SLL is important because you will have to know the clinical details so that you can answer an analytical question. Okay. And another important thing which usually is asked is in the peripheral blood, we can get these cells which look like they have bursted. These are known as smudge cells or basket cells. Okay, they are known as smear cells or smudge cells or basket cells. These are seen in CLL in the peripheral blood smear. Because these cells are basically the same cells, they are lymphoid cells. They look like lymphocytes, but they are extremely fragile. So when we make the smear, they burst. That's why we get these smudge cells. Okay. Burkitt lymphoma, yes, you have to know what are the types of Burkitt lymphoma. And this is an objective question, starry sky appearance. I hope you can appreciate that in this picture. And this is the African endemic Burkitt lymphoma. Then the next important is the plasma cell neoplasm. This is multiple myeloma. You have to know about multiple myeloma. You have to know the clinical history because plasma cell neoplasms is very important as a clinical history. And these are all abnormal plasma cells in the bone marrow. And the diagnosis is done by measuring the M protein. Okay. And this is in the normal case, you get a polyclonal. That means you get different types of protein in a normal person. Whereas in a myeloma person, you get very specific proteins. You can get IgG with a kappa only. All these are negative. Okay. This is a mycosis fungoides in which there is infiltration of the skin by Sézary cells. Okay, this is a plaque phase. And this is on microscopy. You can see, I hope you can appreciate, this is a stratified squamous epithelium here. And these blue cells are the neoplastic cells which are infiltrating into the epidermis. Okay, so here you can appreciate there is some bit of squamous cells, but here you can see that these cells have totally destroyed the squamous cells, and that is how in the clinical phase you can see those red plaque lesions on the skin. Okay, and the specific thing which can come as an objective question for you is the Sézary cells. These are Sézary cells. I hope you can appreciate that they are lobated. It looks as if like 4 nuclei are squeezed together into one cytoplasm. So this is known as a cerebriform nuclei because they look like the sulci and gyri of the brain. Okay, so these are cerebriform nuclei which are basically Sézary cells, which is seen in Sézary syndrome. Mycosis fungoides is mostly skin lesions, but when these cells go out into the peripheral blood, that is when we call it a Sézary syndrome. So it's a continuation of mycosis fungoides. Hairy cell leukemia, you have to know at least an objective question. Hairy cell leukemia is also one disease in which there is massive spleen, okay, massive splenomegaly, and the diagnosis is by phase contrast microscopy in which you can see these cells with fine hair-like cytoplasmic projections. This is Hodgkin's disease, extremely important. Please go through this table, and you have to know how to draw a Reed-Sternberg cell. This is owl-eyed appearance, binucleated bilobe with prominent macronucleoli which are eosinophilic in color. mirror image of each other. Okay, so these are the points we want you to learn on Reed-Sternberg cell. Nodular sclerosis is when you get broad bands of collagen also in between the lymph node. And in nodular sclerosis, the Reed-Sternberg cells may be uninucleated. Okay, only one nuclei, but they have a kind of a space around it. That's why they are called lacunar cells. Okay, these are all lacunar cells. Then another thing is, this is an objective question, Burbeck granules, which is seen in Langerhans cell histiocytosis. Tennis racket-shaped structures are found in Langerhans cell histiocytosis. This is objective question. And the diagnosis, another thing which you have to know about LCH is the immunohistochemistry. CD1A is diagnostic. Okay, so you have to remember CD1A. Okay, then another thing, hypersplenism, you have to know the triad of hypersplenism. In hypersplenism, the spleen will always be enlarged, okay, and all these features of pancytopenia is there, and when splenectomy is done, then the correction of blood cytopenias happen.